Let's talk about left anterior fascicular block. Left anterior fascicular block. So before going to the left anterior fascicular block, we should know the basic anatomy which is very important here. So the normal electrical system consists of a SA node, which is the pacemaker. So SA node goes and depolarizes the AV node. From the AV node, this comes is the bundle of His, and this bundle of His then it divides into what is called as the anterior fascicular, anterior fascicle, and posterior fascicle. You can see here that anterior fascicles generally goes from here towards the left ventricle. The posterior fascicle goes directly downwards to the apex. Okay, this is very important to be known because based on this only we get the ECG features. So you should be aware that the left ventricle fascicle goes directly towards the ventricle on this side, the free wall of the ventricle, whereas the left posterior fascicle generally goes towards the apex. So now in left anterior fascicular block, what happens is that, so in left anterior fascicular block, when if these fibers are blocked, the depolarization wave will initially go into the left posterior fascicle block. So normally there will be left posterior fascicle block will get activation. So activation will occur here initially, and so all the vectors are going in the direction of lead 2-3 AVF. So initial activation will occur at the lead 2-3 AVF. So there will produce a small R wave because the voltage generated is not sufficient. There will be a small R wave will be there in the lead 2-3 AVF. Okay. And later on, what happens whenever this get anti-rotation get activated, all these things will go and then depolarize this major ventricle here. This major ventricle direction depolarization from here to here. That is in the direction of lead 1, V5 and V6. So lead 1, V5, V6 will produce a dominant R wave. Dominant R wave in lead 1, V5, V6 and a small R wave in lead 2, 3 AVF is a feature of what is called as left anterior fascicular block. We'll see a left axis deviation. We will see a small Q and R complexes in the lead 1 AVL. As I said here, 1 in AVL, you will see a dominant R wave and a small R, and S complex will be seen, that is 2-3 AVF, you will have a dominant S wave. And as prolonged R wave peak time may occur. Prolonged R wave peak time is occurring because R wave peak time is nothing but is the starting of the QRS to the peak of that. This R wave peak time will be more than 45 milliseconds because there is a delay in ventricular depolarization because of a left anterior fascicular. So you can see here in the lead 1 and AVL, I said because there is a dominant direction is in this direction, major ventricular depolarization is in this direction. You will see 1 and AVL positive R wave. And in the inferior leads, you will see a small R wave and the deep S wave. S wave can be seen. This is suggestive of a left anterior fascicular block.